Antiphospholipid syndrome is an autoimmune disorder that you must always consider in your differential with lupus. The nuts and bolts are as follows. Clinically, you'll hear about a history of a clot or spontaneous abortion in the first trimester. On the labs, there will be lupus anticoagulant, anticardiolipin, or anti-B2 glycoprotein antibodies. Here's the thing you have to know for the boards. These patients also can have false positive VDRL and prolonged PTT. Remember, even though their PTT is elevated, they are still hypercoagulable because the elevated PTT is an ex vivo effect. In the body, the PTT is actually not elevated. Now, what does a positive VDRL make you think? That's right, syphilis, so be careful and think twice, especially in your young women with spontaneous abortions. Flash quiz. What is the most common cardiac complication in lupus? Pericarditis, followed by Liebman-Sachs endocarditis. Mixed connective tissue disease, otherwise known as MCTD, is sort of a grab bag disorder consisting of a various collection of symptoms from other diseases, such as scleroderma, myositis, lupus, and others. MCTD generally presents with joint pain and swelling, Raynaud phenomenon in the extremities, and myositis, as we previously mentioned. They can also have sclerodactyly, or thickening of the skin on the face, fingers, and toes. The big takeaway from this slide are the lab values associated with the diagnosis. Really, they're the only way you can distinguish mixed connective tissue disease from these other very similar autoimmune conditions. It'll have a positive ANA secondary to its autoimmune nature, but the most important lab value is the positive anti-U1 RNP, otherwise known as the anti-U1 ribonucleoprotein complex. The presence of these specific antibodies is nearly pathognomonic for MCTD, and their emergence often precedes the onset of the clinical disease itself. Sarcoidosis is a disease that is marked by widespread formation of what classically are described as non-caseating granulomas, whereas the granulomas in diseases like tuberculosis are known for their caseous necrotic center. These granulomas appear cleaner, without the same necrotic interior. On histology, there are two other important findings: Shaman and asteroid bodies, which are worth remembering. The Shaman body, seen here on the left, is basically just a collection of calcium and protein within a giant cell, that giant cell being part of a granuloma. Now, similar story here in the asteroid body, basically a collection of lipids within a giant cell, which is also a part of a granuloma. And the interesting thing about this asteroid body is that it looks like a star. So think S for star and S for sarcoidosis. Now, who gets sarcoid? This disease is very common in African American females. There are an incredible number of presenting complaints for patients with sarcoidosis, and as such, it would be worthwhile to try to get a sense of what all of them are. Nevertheless, in terms of answering step 1 questions, if you see a vignette that describes a young African American female with a respiratory problem, sarcoidosis should shoot pretty high up in your differential. Now, what is the most important presenting symptom? You guessed it, restrictive lung disease, and the chest x-ray will classically show bilateral hilar lymphadenopathy or reticular opacities. Aside from this, other signs include Bell's palsy, erythema nodosum, and uveitis. Laboratory findings usually reveal two classic findings. The first is an elevated level of a converting enzyme found in the lungs that relates to water retention in the kidneys and maintenance of blood pressure. Can you guess which one? Very good, angiotensin converting enzyme, or ACE. The second sign is an elevated calcium level. Now, why would calcium be elevated? Because the macrophages in the granulomas activate more vitamin D, leading to increased gut absorption of calcium, and thus hypercalcemia. How do you think this would affect PTH levels? Well, it would decrease serum PTH. One more finding on labs you may see is an elevated CD4-CD8 ratio. The management for sarcoidosis is admittedly very complicated, but what you should know is that patients who do appear to require acute treatment often benefit from steroids. Flash quiz. What are the important histologic findings in sarcoidosis? Non-caseating granulomas. The next disease that we'll discuss is polymyalgia rheumatica, a disease marked by pain and stiffness in proximal muscle groups and joints, namely the hips and shoulders. There are often constitutional symptoms as well, including fever, malaise, and weight loss. Now, what should you look for in the clinical presentation? A woman older than 50 complaining of muscle pain without muscle weakness on exam. The most important piece of this disease to recognize for your board exams is that it is often associated with temporal or giant cell arteritis. That means that patients may either present with both or have a history of one with the second presentation with the other. Either way, keep the two linked in your head in case they do present together. What physical exam maneuver will help you diagnose temporal arteritis? Palpating the temporal artery. How is temporal arteritis diagnosed? Biopsy. There is no single lab finding that will help you confirm the diagnosis of polymyalgia rheumatica, but an elevated ESR in an otherwise healthy patient may be a nonspecific sign of inflammation caused by this disease, and as a side note, also of temporal arteritis by itself. C-reactive protein may be increased as well, another general sign of inflammation. CK values are normal, indicating that there is no breakdown of the muscle itself, as will happen in disease like polymyositis and dermatomyositis, which we'll discuss in a few minutes. How would you treat both PMR and temporal arteritis? As with most autoimmune diseases, use steroids, namely prednisone, which can change the patient's clinical appearance from phenomenal pain to virtually asymptomatic within a couple of days. Fibromyalgia is an interesting disease and a good one to keep on your differential when you're on the wards. The typical clinical vignette consists of a middle-aged woman who complains of diffuse pain all over her body, concentrated around a large number of points with no apparent physical cause. This is normally associated with several other symptoms, such as stiffness, paresthesias, poor sleep, and fatigue. Now, why does it happen? Well, perhaps due to a neuropsychiatric etiology. Because there is no as yet agreed upon cause, treatments vary considerably, though some patients respond to antidepressants and anticonvulsants. It will likely not be tested on step 1. Flash quiz. What lab value is aberrant in polymyalgia rheumatica? General inflammatory markers, such as an increased ESR and CRP. The next two diseases are tough to keep straight, likely because they're fairly obscure, they sound similar, and they always are mentioned and taught in tandem. I bet you'll see one of these two diseases on your exam. These two diseases are polymyositis and dermatomyositis. Polymyositis is a disease marked by progressive, symmetric proximal muscle weakness, not pain. Classically, like PMR, it includes proximal muscle groups. Now, how is the diagnosis made? Well, you need an actual muscle biopsy. The biopsy will show perifascicular inflammation and CD8 T cells. Inflammation is around but not in the muscle fascicles. Look for a younger person with shoulder weakness in the vignettes. Now, in dermatomyositis, the muscular complaints are similar, but the operative change is in the word, dermato, or the skin findings. Now, what are these nodules called? Good. Gottron's papules, which are classic findings, and there may also be wearing of the hands that is described as mechanic's hands. You may observe a malar rash or a heliotrope rash, which you'll see pictured here. Do you remember what disease we discussed earlier also presents with a malar rash in many cases? Correct. Lupus, the great imitator. It's important to know that patients may develop amyopathic dermatomyositis, meaning all the skin findings of dermatomyositis but no changes to the muscles. The muscle damage may start late in the course of the disease or may never occur. Dermatomyositis muscle cell injury is induced by CD4 T cells. So, which would you rather, dermatomyositis or polymyositis? I'd probably pick polymyositis because there's no rash, and also dermatomyositis can be associated with underlying malignancy. As we've discussed, You can make the diagnosis with biopsy, but usually the best confirmatory evidence is actually done by laboratory testing, often with increased CK in aldolase, as well as a positive ANA, anti-Jo1, anti-SRP, and anti-MI2 antibodies. The treatment? You guessed it, steroids, followed by long-term immunosuppressant treatment, like methotrexate. Flash quiz. Dermatomyositis is associated with inflammation with what type of T cells? That's CD4 positive T cells. CD8 positive T cells are associated with polymyositis.